Okay, if you've ever worked in a hospital, you know exactly what this is, the central line. It's that three-port catheter. It's literally a lifeline for our sickest patients. But here's the thing. Those three ports, they look identical, right? But behind them, there's a system of incredible precision at play.
So that brings up the big question, right? I mean, they all feed into the same big vein. So who cares which port you use for what? Does it really matter? Well, the answer is a huge flashing lights yes. Getting this wrong isn't just, a matter of style or preference. It can have seriously dangerous consequences for your patient.
All right, so let's dive in. And we're actually going to start at the very end, the tip of the catheter. This port right here is the distal lumen. The best way to think about it? It's the high-flow highway, the main interstate, heading straight into the body's central circulation.
Now, what makes the distal lumen so powerful is all about location, location, location. Its exit port sits in this prime real estate, right where the superior vena cava meets the right atrium. I mean, it's practically knocking on the heart's door. And being that close gives it two critical superpowers: amazing flow and incredibly accurate monitoring. And because it's got that VIP spot right next to the heart, the distal lumen is the undisputed champ for three key jobs. Number one, it gives us the most spot-on readings for central venous pressure, or CVP, that critical number for figuring out a patient's fluid status. Number two, since it's sitting in some seriously fast-moving blood, it's perfect for getting clean blood samples. And number three, when things go south and you need to push fluids fast, this is your go-to.
So why is it so good for high flow? Well, it all comes down to physics. There's this thing called Poiseuille's law, and it basically says that flow is proportional to the radius to the fourth power. That's huge. It means that because the distal lumen is the widest one, it doesn't just have a little more flow, it has exponentially more. We're talking a massive, game-changing boost in how fast you can push fluids or blood. It's kind of mind-blowing.
And this is a perfect example of why you just can't pick any old port for CVP monitoring. If you tried to use one of the other lumens, which, remember, sit further away from the heart, your readings would be all muffled and totally inaccurate. The distal port is the gold standard for a reason. It's got its ear right up against the heart's door, listening to the real story. Okay, let's move on to the next one in line. This is the medial lumen, and honestly, it's probably the most misunderstood of the bunch. Its special power doesn't come from its physical design. It comes from how we, as clinicians, protect it for one very, very specific job.
So here's the key takeaway for this one. There's really nothing physically special about the medial lumen itself. It's not bigger or smaller. It becomes special because we make it special. We designate it as the one dedicated protected line for giving TPN, or total parenteral nutrition. That super specialized IV nutrition for patients whose guts just aren't working.
So why does TPN get this VIP red carpet treatment? Well, because it's a really complex and frankly high-risk infusion. It needs a super stable, continuous flow with zero interruptions. By setting aside the medial lumen just for TPN, we make sure it's the port we mess with the least. And that simple act drastically lowers the risk of a CLEP-SI, a central line infection, which is a super serious but totally preventable complication. Just think about it. If you tried running TPN through the distal port, say goodbye to your accurate CVP readings. If you tried it in the proximal port, you're setting yourself up for potentially dangerous drug interactions. See? The medial lumen is all about creating that safe, quiet, isolated channel that TPN absolutely has to have. And that brings us to our third and final port, the proximal lumen. So if the distal is that big, high-speed highway, think of this one as a quiet little side street, built for precision, control, and very careful delivery. Okay, so the exit for the proximal lumen is actually the closest one to the patient's skin, where the catheter goes in. Now, that might sound weird, but it means the drug has the longest road to travel inside the catheter before it hits the bloodstream. It exits way upstream from the others, creating this nice, controlled, low-flow zone that's just perfect for our most powerful medications. And this is exactly why it's the #1 absolute best choice for vasopressors. We're talking about those really potent drugs like noradrenaline that need to be titrated just so. Because it's so far separated from that high-flow distal line, we can give a really steady, predictable dose without ever worrying that a big gush of fluid is going to accidentally flush it all in at once. And let's talk about the danger zone for a second, because this is serious. Imagine running your vasopressor through the distal, that high-flow highway. Now someone decides to give a rapid fluid bolus for resuscitation through that same line. What happens? Whoosh! You've just blasted a huge unintended dose of that powerful drug straight into the heart. You're looking at dangerous blood pressure spikes, arrhythmias. It's a nightmare scenario. The proximal port is designed to prevent exactly that.
Okay, so we've looked at 3 different ports, 3 totally different jobs. Let's pull it all together now and find the one simple rule, the golden rule, that makes this whole system work so beautifully.
Yeah, this table really breaks it down perfectly. You've got the distal, high flow, close to the heart, that's for your CVP, blood draws, and big fluid pushes. Then you've got the medial, stable and hands-off, that's your dedicated TPN line. And finally, the proximal, controlled and isolated, that's where your vasopressors go. Simple, right? And that brings us to the real golden rule, the big idea behind all of this. It's not about randomly assigning ports or just memorizing a bunch of rules. It's about something much smarter. We are intentionally matching the job we need to do with the physics of the catheter and the absolute bedrock principles of patient safety. Every single choice has a reason. So the next time you're on the ward and you see a central line, I really hope you don't just see 3 plastic ports. I hope you see 3 completely different environments. You've got a high-speed highway, a quiet, protected lane, and a precision side street. All of them designed and chosen for a specific reason, all working together for safety, for precision, and ultimately for survival.